welcome back to the deep dive. You asked, and we've listened. Today, we're tackling orbital cellulitis, really getting to the weeds for revision.
Absolutely.
We've taken a load of revision notes, now boiled them down to the essentials for you. Our mission today, clarity, and making sure this stuff actually sticks. We'll break it down, hit the key points, maybe throw in some memory aids. Sound good?
Sounds great. Orbital cellulitis. It's one of those conditions where things can escalate quickly, right? From what seems like a local issue.
Yeah, exactly. So what are we actually talking about, definition-wise?
Okay, so fundamentally, it's a serious bacterial infection, and it's within the eye socket, the orbit.
Okay, inside the socket.
Right. But crucially, it's behind a structure called the orbital septum. Think of it like a thin sheet, a kind of barrier.
A barrier.
Yeah, and the infection is behind that barrier. Importantly, it doesn't usually involve the eyeball itself, just the tissues around it in the socket.
Got it. So that orbital septum is the key dividing line then.
Exactly. Because you can get preseptal cellulitis, which is an infection in front of that septum.
Oh, okay.
That's usually less serious, more about eyelid swelling, redness, but without those deeper orbital signs we'll get into.
Right, so orbital has crossed that line. What does it usually come from?
Typically, it's bacteria spreading from nearby. The sinuses are a really common source, especially after, say, an upper respiratory infection.
Sinusitis, okay.
Or sometimes from the eyelids themselves, or even dental infections.
And what are the visible signs we should be looking for? The ones that scream orbital.
You'll likely see quite dramatic eyelid swelling that's edema, significant redness, erythema, and sometimes swelling of the conjunctiva, the lining of the eye. We call that chemosis.
Chemosis.
Plus other signs involving the orbit itself, and often the patient will have a fever.
Okay.
The main thing to stress is, this is serious, a proper medical emergency. Needs hospitalization, specialist review, fast.
Absolutely.
Yeah.
That septum really is the crucial boundary, isn't it? Separating the OCO from the okay but serious.
Precisely. That's the anatomical key.
Okay, definition clear. Let's talk etiology. What's kicking this off, the origin story?
Well, like we said, that bacterial spread from nearby infections is the big one. Sinuses, definitely.
Number one culprit.
Often, yeah, especially in children. But dental infections, eyelid infections, they can all be the starting point.
And which bacteria are we usually dealing with?
The main players are Streptococcus pneumoniae and Staphylococcus aureus. If you can just remember, Strep and Staph.
Strep
Covers the most common ones.
Easy enough. Strep and Staph. Okay, so who's most likely to get this? Risk factors. Let's maybe group them to make it easier to recall.
Good idea. Let's think. Categories. Okay, first up, age.
Age.
It can affect anyone, but it definitely has a preference for children. Peak hospitalization age is around 7 to 12 years old, sort of school-aged kids.
Right, school age, got it. Next category.
Prior infections. This is a big one. A recent sinus infection is probably the most common link.
Makes sense.
But also recent infections of the eyelid, ear, or face. Even just the standard upper respiratory tract infection can sometimes precede it, like a setup.
Domino effect, yeah. One thing leads to another.
Exactly. Then immunization status.
Vaccinations.
Specifically, lack of the HYIB vaccine, that's Haemophilusinfluenzae type B, not being vaccinated increases the risk. Maybe think HYIB, higher risk.
HYIB, higher risk. Like it. What else?
Trauma or procedures, any recent injury near the eye or eye surgery.
Okay.
An insect bite is sometimes mentioned, though maybe more commonly linked to Preseptal. And here's one that might surprise you. Eyebrow piercings.
Really? Eyebrow piercings?
Yeah, they've been linked to both Preseptal and occasionally orbital cellulitis, something to keep in the back of your mind.
Definitely one I wouldn't have immediately thought of. Okay, last category.
Last one, systemic conditions. So anything that compromises the immune system.
Like diabetes.
Diabetes, yes, or other immunodeficiency states. And it's worth remembering, too, especially in kids, that preseptal cellulitis can sometimes progress to orbital if it's not treated properly.
Okay, good point. So that's who's at risk.
Yeah.
Let's dive deeper, the pathophysiology, what's actually happening inside the orbit.
So in orbital cellulitis, you get this infection starting in the soft tissues within the eye socket. This triggers inflammation, and because it's a confined space, things can happen fast.
Right, it's all packed in there.
Exactly. The inflammation spreads rapidly, potentially affecting the eye muscles, the fat, even the optic nerve. It's like, well, like setting off a firework in a small box, things get messy quickly.
Wow, okay. Nasty analogy. And the spark for this firework, Where's the infection usually coming from?
Often it's direct spread, extension from those nearby structures, sinuses being the main one.
Sinuses again.
Yeah, but also direct trauma or after surgery. Less commonly, it can spread through the bloodstream from somewhere else that's hematogenous spread.
And the bacteria causing this fireworks show? Still strep and staph.
Predominantly, yes. Streptococcus pneumonia, Staphylococcus aureus, also Streptococcus pyogenes, and Haemophilus influenza.
Okay.
And really important to remember nowadays is MRSA, methicillin-resistant Staph aureus, can make treatment trickier.
Right, MRSA.
And then there's a rare but critical one, mainly in immunocompromised people, mucormycosis, a nasty fungal infection that can move incredibly fast.
Fungal. Mucormycosis. Okay.
Yeah, maybe think mold in the immunocompromised is bad news. It's a stark one, but important.
Definitely memorable. How does the pathophysiology differ for preseptal cellulitis then?
With Preseptal, the whole process stays in front of that orbital septum.
The firewall.
The firewall, exactly. It's usually spread from a local skin, break a cut, scratch, insect bite near the eye, or maybe a local infection like a sty, or even from the face or upper respiratory tract.
And different bacteria usually.
Often, yes. You see more S. aureus and S. epidermidis from the skin, other streptococci, sometimes anaerobes too.
Anaerobes.
MRSA can cause Preseptal too, of course, and there are those really rare ones like anthrax or smallpox vaccine complications, but they're highly unlikely. The key thing is that septum usually does its job and keeps the infection contained anteriorly.
The septum as a firewall really helps visualize it. Okay, so we know what it is, how it happens, what else could look like this. Differential diagnosis time, this must be crucial.
Absolutely vital. Getting it wrong can have serious consequences. Top of the list, obviously, is distinguishing it from preseptal cellulitis.
Right, the main mimic.
And as we've hinted, the key orbital signs help here. Remember proptosis, the eye bulging out, ophthalmoplegia, difficulty moving the eye, pain on eye movement, and reduced vision. Maybe think POOPR.
2PR. Pop goes the eye, ouch it moves, poor vision, love it.
Yeah, something like that. If you see those PPR signs, think orbital. If not, lean towards preseptal.
Okay, PPR for orbital. What else is on the differential list?
Well, you could have necrotizing fasciitis.
Yeah.
Very serious skin and tissue infection can cause massive swelling. A chalazion blocked eyelid gland causes local swelling, but usually no fever or those POPR signs. Allergic lid swelling can be dramatic, but often itchy, bilateral maybe, no real infection signs.
Okay, more localized things.
Severe viral conjunctivitis can cause some redness and swelling, but again, usually lacks the proptosis and ophthalmoplegia.
Right. Any really serious mimics we need to rule out?
Cavernous sinus thrombosis, that's a big one. Rare, but dangerous.
How does that differ?
You can have proptosis and chemosis, but you often see more cranial nerve palsies affecting eye movement, more severe vision loss usually, and the patient is often systemically very unwell. Think CST has widespread nerve issues and hits vision hard.
Okay, CST sounds even more alarming. Anything else?
You could consider erysipelas, a type of skin infection, but it usually has a very sharp raised border. Then there are other orbital conditions like thyroid eye disease or even orbital tumors or inflammation like pseudotumor or vasculitis. But these tend to develop more slowly.
Slower onset, okay.
And finally, maybe things like a severe insect bite reaction, angioedema causing rapid swelling, or even maxillary osteomyelitis, an infection in the upper jawbone spreading up.
Wow, quite a list. So it really comes down to looking for those specific orbital signs, the POPR features.
Exactly, the whole clinical picture, but POPR is key for suspicion of orbital.
Got it. Let's talk numbers. Epidemiology. How common is this actually?
In the UK, it's relatively uncommon. Estimates are around 0.3 to 0.6 cases per 100,000 people per year.
So not every day, but common enough to need to know about.
Definitely. And it's more common in children and young adults.
And you mentioned seasonality.
Yeah, both orbital and preseptal tend to pop up more in winter, likely linked to the increase in sinus infections then. Remember, winter, more sinus, more cellulitis.
Winter, more sinus. More cellulitis. Makes total sense. And how many sinus infections actually lead to this orbital complication?
Thankfully, only a small fraction. Studies suggest somewhere between 0.5% and maybe up to 3.9%. So most sinusitis doesn't lead to this.
It's reassuring. Any gender or ethnicity links?
No strong ethnic link usually reported. But in children, interestingly, boys seem to get it about twice as often as girls.
Huh. Wonder why that is.
Not entirely clear. And just to recap ages, orbital peak 7-12 years, preseptal tends to be younger kids.
Okay, good overview. Now the really practical bit. Clinical features. What does someone with orbital cellulitis actually look like? What do they complain of?
This is where we put it all together. Locally, you've got those prominent signs.
Right.
Significant eyelid swelling, redness, pain, often unilateral swelling of both the conjunctiva chemosis and the eyelids.
And the big one.
Proptosis, the bulging eye, that's a real hallmark. We could maybe use predopo, proptosis, redness, edema, ocular signs, pain.
Pretty detailed. Now they're going proptosis, redness, edema, ocular signs, pain. Nice.
And that's
So,
just how it looks, right?
functional issues too.
Absolutely crucial. The ocular signs, vision might be reduced, eye movements difficult or painful. That's ophthalmoplegia.
The OMP and POPR.
Exactly. You might see ptosis, a droopy eyelid. Patients often report pain on moving the eye, blurred vision, maybe double vision diplopia.
Diplopia. Okay.
And you might find a relative afferent pupillary defect, an RAPD, that points towards optic nerve problems, which is really serious territory, risk of permanent vision loss.
Very concerning signs. So these are the bedside clues that shout orbital, not preseptal.
Yes. Reduced visual acuity, proptosis, ophthalmoplegia, and significant pain on eye movement. Those are the key differentiators. If those are present, your suspicion for orbital should be high. Remember, no POPR in Preseptal.
No PPR in preseptal. Keeps it straight.
It can be tricky initially. Sometimes the signs aren't all fully developed, but if you see decreased vision, proptosis, or ophthalmoplegia, you have to treat it as orbital until proven otherwise. Delays, dangerous vision loss, meningitis, brain abscess.
Yeah, stakes are high. Any differences in kids versus adults?
Children are more likely to present with systemic signs like fever and a high white blood cell count, leukocytosis.
Okay, fever and high WBC count extra clues in kids. And just to contrast again, what does preseptal look like?
Yeah. Preseptal gives you the eyelid swelling, redness, warmth, tenderness, it looks infected. But crucially, without those orbital signs, no proptosis, no significant ophthalmoplegia, usually normal vision. They might have a fever or feel unwell, especially kids, maybe some ptosis just from the swelling. But the eye itself moves okay, vision's okay, and it's not bulging.
Okay, that comparison is crystal clear. So we suspect orbital cellulitis based on these features. What tests do we order? What's in the investigation toolkit?
Right. You need to confirm and figure out the cause. Start with blood tests.
Standard bloods.
Yep. Full blood count, looking for that raised white cell count. Inflammatory markers like CRP and ESR will likely be up too. Think bloods for bugs and body's response.
Bloods for bugs and body's response. Got it. Then
A thorough clinical examination, specifically an ophthalmology assessment. Checking vision carefully, pupils for RAPD, looking for proptosis, assessing eye movements fully, checking for pain on movement, and documenting the redness and swelling. Think eyes examined for orbital clues.
eyes examined for orbital clues. Makes sense. Imaging.
Imaging is key here. A CT scan, usually with contrast, is the investigation of choice.
Why CT?
It's great at showing the soft tissues behind the septum, any inflammation or abscess formation there. Plus, it assesses the sinuses really well, looking for that underlying sinusitis. Think CT to see behind the septum and sinuses.
ET to see behind the septum and sinuses. Perfect. And finding the actual bug.
Microbiological cultures? You take blood cultures, definitely. Swab any discharge from the eye or nose, maybe throat swabs too. Trying to isolate the bacteria, Strep, Staph, Haemophilus. Think cultures to catch the culprit bacteria.
Cultures to catch the culprit bacteria. Good set of mnemonics there. Any caveats with these investigations?
Yeah, a few things. Remember, the diagnosis is often primarily clinical, based on those signs. Investigations support it and guide treatment. This all typically happens in hospital, obviously. Blood cultures might be negative, especially in adults, doesn't rule it out. CT is pretty much standard if you suspect orbital. MRI might be used if you're worried about cavernous sinus thrombosis or other specific complications. And generally, avoid a lumbar puncture until a CT scan has ruled out raised intracranial pressure.
Right, don't want to risk herniation. Okay, investigations covered. Diagnosis confirmed. Orbital cellulitis. How do we manage it?
Swift action is needed. Number 1, immediate hospital admission.
Okay.
Absolutely. And start intravenous antibiotics promptly. The usual first choice is coamoxiclav.
Coamoxiclav. What if they're penicillin allergic?
Then clindamycin plus metronidazole is a common combination. For severe cases, or if you need broader cover, options like IV cefuroxime or ceftriaxone come into play. And crucially, if you suspect or know, it's MRSA.
Needs specific cover.
Yes. Add something like IV vancomycin or teicoplanin. maybe line solid. Think Vanco for MRSA.
Vanco for MRSA. Okay. When do we absolutely need to get specialists involved urgently, like call ophthalmology or ENT stat?
Emergency referral is needed if you suspect orbital cellulitis at all, if the patient is systemically unwell, if it's any child with suspected preseptal cellulitis to rule out orbital, if the diagnosis is uncertain, or if preseptal isn't getting better after a day or two of treatment. Also, if there's an eyelid abscess needing drainage.
Okay. Pretty clear criteria.
Yeah.
How is preseptal cellulitis usually handled then?
For kids, they often get admitted initially anyway, just for observation and to be sure it's not orbital. Treatment is usually oral coamoxiclav or maybe IV ceftriaxone if they can't take oral or seem quite unwell, and no allergy. You'd expect improvement in 24-48 hours.
Right. And back to confirmed orbital cellulitis, the specific plan in hospital.
Definitely needs admission under both ophthalmology and ENT, especially if sinuses are involved.
Joint care.
Yes. For by antibiotics, as discussed, maybe switching to oral later if improving well. Regular, close monitoring of vision and optic nerve function is absolutely critical. Checking visual acuity, pupils, color vision, brightness perception.
How long for treatment usually?
Typically around 7 days of antibiotics, but guided by clinical response. And sometimes surgery is necessary.
When would surgery be needed?
If there's a definite collection, an abscess, in the orbit seen on CT. If the patient isn't responding to antibiotics after, say, 48 hours. If vision starts to deteriorate despite antibiotics, or if the presentation is very unusual. Surgery might involve draining the orbital abscess and often draining the involved sinuses too.
Okay, so antibiotics, close monitoring, potential surgery. What's the outcome usually like? The prognosis?
Generally, with prompt diagnosis and the right treatment, the prognosis for orbital cellulitis is actually pretty good. Most people recover well.
That's good to hear.
But if treatment is delayed or inadequate, the potential for serious complications is significant.
Yeah.
Vision loss, optic nerve damage, abscess is spreading.
Right, and for preseptal?
Prognosis for preseptal is usually excellent. Quick treatment normally leads to full recovery.
So early action is the name of the game for both, but especially orbital.
Yeah.
Any factors that worsen the prognosis for orbital?
Speed of treatment is the biggest factor. Being immunocompromised definitely increases the risk of complications. And as we mentioned, that rare fungal cellulitis carries a really high mortality rate.
Really underscores the urgency. Can we do anything to prevent this in the first place?
Well, for the Haemophilusinfluenzae component, the HYIB vaccine is key. Routine childhood immunization.
Vaccination again. Crucial.
Absolutely. For preventing preseptal, some might use prophylactic antibiotic ointment for eyelid cuts or trauma, but evidence is limited. For orbital, the main prevention is really about good management of the predisposing factors.
Like sinusitis.
Exactly. Treating sinusitis properly and promptly is probably the best way to reduce the risk of it spreading to the orbit. And maybe using antibiotics appropriately after significant eye trauma or surgery.
Makes sense. Treat the source.
Yeah.
Okay, last bit, complications. If things do go wrong with orbital cellulitis, what are we talking about?
They can be broadly grouped. Ocular complications affecting the eye itself. Things like exposure keratopathy, where the cornea gets damaged because the eyelid can't close properly due to swelling.
Ouch.
Raised intraocular pressure, blockage of the retinal artery or vein, which can cause sudden vision loss, infections spreading inside the eye, endophthalmitis, and optic neuropathy damage to the optic nerve.
All potentially blinding. What about complications within the orbit itself?
The main one is an orbital abscess, that collection of pus. Can cause profound vision loss. Also, a superiosteal abscess, which forms between the bone and its lining, often on the inner wall near the sinuses. That carries a risk of spreading upwards intracranially.
Intracranially, that sounds bad.
Yes, intracranial complications are rare, thankfully, but the most serious, meningitis, brain abscess, and that cavernous sinus thrombosis we talked about, all potentially life-threatening.
Wow. That really hammers home why this is an emergency. Okay, let's try and wrap this up. Key take-home messages for orbital cellulitis.
I think the absolute keys are: recognize it's a serious infection behind the septum, distinct from preseptal. Look for those POPR signs: proptosis, ophthalmoplegia, pain on movement, reduced vision.
POPR.
Get help, fast, immediate hospital referral. Start 4 antibiotics promptly, usually coamoxiclav plus MRSA cover. Involve ophthalmology and ENT. Monitor vision closely. And remember, the commonest cause is sinus infection spread. Understanding the potential complications, vision loss, abscess, intracranial spread really highlights the urgency.
Brilliant summary. And maybe a final thought for everyone listening. Given that strong link to sinus infection,
Yeah.
perhaps think about everyday things, simple hygiene or allergy management. That might help reduce the risk of those initial sinus problems kicking off. Just something to consider.
Good point. Prevention starts early.
Definitely. If you want more details, revision tools, questions on this, head over to passthemsra.com.
And for loads of great free resources, check out fromsinusitis.com too.
Thanks so much for joining us for this deep dive into orbital cellulitis today. Hope it was helpful.